would like to introduce Gerald Harmon, who's president to the American Medical Association, and he's going to be in a fireside chat with Geeta Nayyar, who is the Chief Medical Officer at Salesforce. Please.
All right, well, good morning, Dr. Harmon. Thank you so much for doing this.
Good morning. Thanks for letting me be here today.
So these lovely people have come here today because there's a lot going on in telehealth. And as we think about the priorities of the AMA and where the industry should be, what are the top telehealth policy priorities that you see?
You know, first off, let me comment. We have a lot of what I would call silver linings, and I'm a perpetual optimist, so forgive me for being almost a pathologic optimist. We're in the cloud of a pandemic, the storm of a pandemic. We have so many linings, so silver linings, that we've learned so much. One of the things that we've learned is the value of telehealth, the opportunities for it. What we've also learned as a society is that healthcare is kind of embedded in everything we're doing. So it's public health. I was in the military for 35 years. I learned that force protection, when you went into a new environment, first thing you did was establish a perimeter. The second thing was have health care. All of us as employers, as industry, as professionals understand health care should be at the very root of any infrastructure. Our public health infrastructure has been embarrassed with the pandemic. We need to be prepared not only for what we're doing now next week, but the next pandemic, because there will be another one. Telehealth, AMA's priorities on telehealth. We've realized the value of telehealth. We show that 85% of doctors find that telehealth is very beneficial. 70% intend to continue it after the pandemic and forever as part of their practices. We're worried about access, coverage, and payment. Access means everybody can get it. We ought to have access to health care via telehealth. It needs to be covered by the insurance plans appropriately, regardless of the site of service. We'll talk about that later on. Then payment needs to be not at this expense and the degradation of on-scene, in-person coverage. It needs to be paid for appropriately and comparatively to in-person coverage.
So I think we can all appreciate it's been a tough 2 years. And two things that we learned about the healthcare system is, number one, we need to increase access to care. And number two, there are too many disparities in our healthcare system. How can telehealth increase access to care and mitigate the disparities that we have here in the U.S.?
I'm in small town America. I'm literally a country doctor, like Michael J. Fox.
They call him Doc Hollywood, for those of you who don't know.
I feel like, and it is, when I looked at Michael J. Fox in that Doc Hollywood movie, I said, I don't get paid in chickens, but I've been paid in flounder, in corn, in watermelons, and in shrimp. The only challenge I had was whenever the well-intended patient decided to pay me in flounder, he had them still on the stringer. And I wasn't going to clean these flounder and all. I had to tell them, no, I'll take them if they're cleaned and frozen perhaps, but I don't want a stringer fish in my lobby. They start to smell after a while. But the access to care coverage is so important in small town America. I have patients that have a hard time driving to my area. They have to cross rivers and swamps, and they have geographic limitations. They're not that most mobile either sometimes. So telehealth allows access to a quality healthcare system, not only in the pandemic, but in sustainable modes afterwards.
You get to avoid the gators too, right?
Well, there are gators, and lately where I live in rural South Carolina, there are bears. So, but the reality is, it's the geography, it's not the wildlife.
That's right. So there are folks out there that would say telehealth is substandard care. It's not really practicing medicine. I think we heard a little bit about that from Roy and sort of physicians' perception of telehealth. How can telehealth effectively meet the standard of care and really remove that tarnish?
Well, we've done studies. The AMA has done studies. We've partnered with Manat to show that there's value in chronic disease management in healthcare. And we can do it as a telehealth provider. I have obligations to provide quality care, Dr. G. We do that. I need to establish the patient's identity just as I would ordinarily so that I'm not misappropriately gathering data on the wrong patient. I need to make sure I've got the background necessary to get decision quality data so I can give them a quality diagnosis and recommendations. I need to document what I'm doing. I need to make sure that documentation lives past the encounter so that it becomes part of the medical record so that patient has access to it too. And they can say, hey, I did a telehealth with Dr. Harmon the other day. He diagnosed me with something, and they'll read it and they say, erythema, erythema nodosum, or whatever, but there needs to be quality documentation just as it's an in-person visit so that we won't deteriorate standards just because it's telehealth.
So Dr. Harmon, I'm a rheumatologist. There are not a lot of us out there. I have a Florida license, but I get phone calls from colleagues in Utah, Nebraska, California, New York City, because specialists such as myself are really needed, right? And there are many, many patients all over the world, not just domestically. So how do we meet the goal of licensure reciprocity? And what else can advocates do to make headway on the front and to break down barriers to care across state lines, which is a big, big issue?
Geeta, if you're a rheumatologist, can you come home with me and join my medical practice? We need rheumatologists.
I will join you virtually because I'm afraid of gators. I'm not as brave as you.
but you're right. They don't. One of the issues we find at the AMA is physician and healthcare workforce. We just don't have enough. We don't have enough for the day's needs. We don't anticipate enough in the next coming decade. So we need to have physician provider accessibility. We want to make sure that the AMA's position on licensing is that state medical boards need to be accountable for the care of the patient when the patients are in their states, no question of it. But we need to be realistic about it. If one of my patients comes to Boston and gets a procedure done, gets care here that's not available in Pawleys Island or Georgetown, South Carolina, gets care, then that physician needs to be able to take care digitally and do telehealth for that patient afterwards, even though they don't have a South Carolina license. So that's clearly something that we need to look at as a workaround and an allowable option to having a state license in South Carolina versus Massachusetts. That's very important. Same thing when one of my patients is on a 6-month business trip to Boston or maybe to Montana or someplace where I don't have a license. I can still provide medical care when they call me up and say, hey, my asthma is flaring up again. Can you call me in some albuterol inhaler? Let me give you the nearest phone number. That's an audio only, and honestly, I don't even charge them for it because it's just common sense. But I'm practicing medicine, and I document it for telehealth reasons because we just talked about. We have sustainable, documented quality care to the same level as in-person care. At some point, in a perfect world, I could do a good digital health visit and be really documented to make sure it is just asthma and not pneumonias. All those things are important for quality digital care. But yeah, we ought to be able to do that with reasonable exceptions to the standard licensing rules.
How does the recent extensions of telehealth flexibilities in the federal omnibus bill affect physicians and patients? What does this audience need to know?
Well, you know, that federal omnibus bill that's allowed an extension of the current relaxation of telehealth rules until the end of the public health emergency. And I'm told by my advocacy staff that we hope it'll last until this summer in July. And at some point when whoever's in charge declares the pandemic, the public health emergency over, it seems like it's like every other kind of COVID timeline. It's like dog years. We're in COVID months, you know. This current situation is going to extend a little bit longer. So COVID years probably, it feels like 3 to 4 regular years for me. But when the public health emergency is gone, we'd like to see an extension of the relaxation of the telehealth rules so that site of service is not as important. You don't have to be in a specially designated rural health site to qualify for reasonable telehealth. And the ability to do it from just audio only, as opposed to having two-way video communications. That's important also because that access needs to be available after the public health emergency is gone.
So Dr. Harmon, innovation is literally all around us, right? This whole exhibit floor is full of the latest innovations in telehealth, telemedicine. But unfortunately, regulation seems to always hold that innovation back. And as we think about our members of Congress who did not go to medical school like we did, how do we educate our members of Congress who seem to keep taking a temporary extension to telehealth policies? They're not really making that commitment that I think everyone here is looking for in the industry.
You know what, Geeta, we talked about, and you're right, our congresspersons are not closing their minds and eyes here. It takes a while to be a doctor. It takes a while to be a healthcare professional. It takes a learning curve that's pretty steep and a lot of information. So we need to educate them on what we need from them. We talk about, I mentioned a little bit in the omnibus question about what it means after the public health emergency goes away. Will we have site of service independence and payment for that using Medicare and CMS dollars. We need to let them understand there are a couple of bills right now in the Congress, the Telemedicine Act and the Connect Act. I'd like for those folks in Congress to understand those need to be taking effect today so that I can increase access to my rural communities, underserved and even marginalized communities that have the geographic concerns about getting to my office. If we can allow, if Congress can fund telehealth, if Congress can fund the expansion of broadband and internet services and wireless services into not only rural areas, but some inner city urban areas so that people have access and not only to two-way video, but to audio only. We have studies at AMA that shows that 65% of doctors provide health care now, digital care, just by telephone. And you don't have to have a degree in computer engineering. You don't have to know how to log on or remember your password. You just pick up the phone and have a scheduled time. You can say, hey, Dr. Harmon, let me give you my blood pressure numbers. I'm running 144/82, and you doubled my low sartan last week from 25 to 50, but I'm still, I feel a sensation of not feeling well. My blood pressure's this, and I'm taking it standing and sitting down, all the standard stuff. And what do you think? And I said, well, let's double it to 100. Let's give out adequate care, document all of this in the record. If we can make sure that the folks in Congress understand that that's health care too, and by doing this legislation that we ask them to do, they provide an invaluable service to the patients, us in chronic disease management, to the health care of the nation, and will reduce the burden of chronic disease cost, and in the long run have a great return on their investment if they act responsibly and worthy as they become educated members of Congress.
I love that. Thank you, Dr. Harmon. So last question. How do we address the huge issue of clinician burnout, staff shortages, and ensure healthcare workers have a safe place to access behavioral health resources?
You know, we mentioned about Dr. G being a rheumatologist and me being a family doc. Both of us, we're not a endangered species, but we're reproductively challenged. We don't make enough of ourselves. We just don't have enough doctors. We don't have enough workers in healthcare. I don't have enough registered nurses. I don't have enough nursing personnel, respiratory therapists, pharmacists, x-ray techs, you name it. In fact, I use the term in a lot of my discussions and my writings on behalf of the AMA, I don't have enough gurney drivers, people that are just moving, transporting patients from one place to another. There aren't enough workers in healthcare now, and we're looking at thousands, tens of thousands of worker shortages, even doctors in the future. What we desperately need is primary care, extension into the underserved areas, and that's not just rural South Carolina, that's urban Boston sometimes. Enough primary care docs need to be out here to take care of the patient population. If we can help with physician satisfaction and retention, that'll help the burnout issue. We know that 1 in 5 doctors has told us at AMA that they're going to retire in the next 24 months. I'm out of here is what they're saying. It's not just burnout, it's just fatigue, emotional, physical fatigue. 2 out of 5 nurses tell us the same thing. In 24 months, they're going to retire from their profession. And another 20% of nurses and doctors saying they're going to cut their hours back substantially because they're burned out. They're tired. So we have an incredible workforce shortage. The Provider Protection Act, the Lorna Breen Act, is just passed by Congress, signed into law by the President. The AMA applauds that. I personally applaud that. I deal with burnout in my day-to-day practices. I'm having a hard time recruiting and retaining doctors in my organization. There are times even when I get tired. And I'm a professional optimist. I'm like the Energizer Bunny. When I'm getting tired, I know other people are really getting tired. I need to be able to do a couple of things. I need to count on my colleagues to be able to come to me and say, Jerry, you need to slow down a little bit. You need to take a day off. Oh, I'm fine. No, you need to take a day off. It's a suggestion, then it certainly becomes a requirement. We need to make sure that healthcare workers can take that day off and they can seek health without fear of repercussions or attribution or even retribution. We need to make sure that they know, hey, I'm having some hard time focusing on the patient care in front of me right now. I need to be able to take some time off to recharge, to seek care, and not be stigmatized for it and have my license threatened. That's important. You mentioned state medical boards. We need to be able to have licensing bodies and healthcare credentialing bodies take the question off that says, have you ever been treated for emotional problems? Are you undergoing current behavioral health therapy? That should not be a stigma. That should be something that's appropriate. We don't ask them necessarily if they're taking blood pressure medicine. We might not ask them if they have allergies or asthma. It depends on what the questionnaire is. But their licensing and their ability to work should not depend on what type of medications they might be taking. Now, if they're impairing patient safety, that's a different issue. But we need to be able to actively treat and be treated for behavioral health symptoms without a stigma. So that's a big deal.
Very big deal. So I have one more question.
Sure.
And I don't know where the camera is, but you got to zoom in on these socks. Where do I get socks like that, Dr. Harmon? Those are pretty snazzy.
Those are my AMA member socks.
So we got to be an AMA member.
Well, I'm up here, and this, one of the things I've learned when you become president of the AMA is that the mic is always hot. It's like being a member of the clergy. You're always wearing the collar whether you've got it on or not. So if I get a chance to put my socks on in front of a big audience like this, I'm going to stick them on.
All right.
It's a commercial, but they are kind of snazzy, and my grandkids love it.
I noticed. I'm going to have to get some.
They say, "Gee, Daddy, can I get some of those socks?" I said, "When you grow up, and I might be able to get you a pair of those socks that'll fit you." But you're right.
Dr. Harmon, such a pleasure. Thank you so much for doing this.
It's a real honor. Let me tell you how much being a doctor, how important it is to me. I think all of you can sense that I feel like the time is this. This is why I took the oath. Being able to be president of the AMA, speak to an organization such as the ATA, be an invited guest here. This is an opportunity to touch more than one person at a time with my stethoscope. I can touch a couple of hundred back in small town South Carolina, but I get to impact and influence, not in charge of, but have influence over the health care of 340 million Americans. For such a time as this, we're here today. Thank you.
Thank you so much. This was great. Thank you so much. I appreciate it.